Well, we are about to, let's see if you can hear me, about to get started. And it is just a wonderful opportunity every month to see some familiar faces and a few new faces. And I'm Matt Wanacott, co-chair, along with Dr. Balmer for this RightCare initiative here in the Capital Region. And it's a wonderful thing, as I said. We have in the past gone around, and I think a lot of people have had an opportunity to meet each other and get to know each other a little bit. You'll continue to have those opportunities as we have other folks come and join us today. But thank you all. We were just talking up here that today, this very day, is the 6th anniversary of holding these conferences here at the Sierra Health Foundation. And so it's a wonderful thing to have been able to keep the momentum, keep going and keep learning and sharing best practices so that we can make a real difference in the community. We'll get started. I'm going to turn the time over to my colleague, Dr. Balmer, who will introduce our speaker, and we'll go from there. Thank you. Thank you so much for attending.
Indeed, welcome and happy birthday to RightCare on its 6th birthday. Now, a 6-year-old is sometimes asked a lot of questions, so feel free to ask any questions during the program today, because 6-year-olds want all the answers as they go through. So this anniversary, 6 years, the question was what happened at birth? And at birth, turns out to be, we're honoring today Dr. Rebelo, who was here at birth and was actually delivered the baby, which is Sacramento Capital RightCare, for which we are all here today. And we're here to honor Dad, I guess, for that. You would be happy to say, well, how does he do all of these things? Because I'm going to read you a list of things that he has done. He is the founding chairman of the Capital Region RightCare University of Best Practices, this program here 6 years ago today. And he has led it for 6 of those years. He's also the chief medical officer for Sutter Independent Physicians, a very large group, over 500 physicians with many specialties. He is president of the Latino Physicians Association of California and prior president of Sierra Sacramento Valley Medical Society for the physicians in this area. He has been a full-time faculty member at UC Davis, research on reproductive health, diabetes and type 2 diabetes, which are one of the focuses of RightCare. He's done initial or continuous work with UC Davis Medical Student Education Program, received the Kaiser Award for Excellence in Teaching, goes to individual who is teaching residents in the program. He is also has been on the California Diabetes Steering Committee and created the Diabetes Coalition of California. He's involved with a significant number of managed care organizations that are working throughout the Sacramento and California area, and continues as chair of the Sacramento Latino Medical Association and serving on the boards of the California Academy of Family Physicians for that. He was the first winner of the California Latino Medical Association Lifetime Achievement Award for outstanding contributions to Latino health issues in 1992. He received the National Hispanic Health Foundation's First Leadership Award. He's been honored for other ethnic physician leadership awards as well. So it's a long list, and I don't want to spend the rest of the morning reading on, but I thought it would be important to pop out of the CV for a second and tell you, how does this guy really work? Well, I found out that he was the first of 7 children. So if you grow up in a family of 7 children and you're the oldest, you have a lot of responsibilities of keeping your other kids in line. The second secret was he had 7 children himself. And if any of you are parents and know how hard it is to keep 1 or 2 kids in line and doing their part, keeping 7 of them going is certainly a large venue and a large responsibility. And if you can handle 7 kids, you can handle any committee, medical education or medical administration, I can tell you, and keep them in line as well. Now, keeping the line of 7 going, born in a family of 7 kids, he now has 7 grandchildren as well. So it's coming back to hit him at this point in time. We're delighted to have Dr. Revelo here. If I could ask him to come forward, I'd like my wingman, Matt, to come up with the award. We are going to present him with the Outstanding Leadership Award for the RightCare Initiative, and culminating in this, our 6th-year birthday today. Dr. Revelo.
We'll keep this right in the package because it's kind of fragile, but we sure appreciate you.
It's beautiful.
And have Brian sit right here to take a photo so we can stand there.
Try not to drop it. 3, 2, 1. Awesome.
Cool. And knowing that he has a little bit of advice for his kids and his grandkids, Dr. Revelo, words of advice.
Thank you, Bill and Matt and Hattie. This is really a great honor, and again, it's a labor of love. This is work that actually, I have to say, Hattie has been really my inspiration with the things that she's. When we first started talking about bringing the San Diego experience up to Sacramento, which is totally different, you know, Hattie was really the spark. And I also have to thank several people, including Parag Anahutre, who's not here, but who was the other co-founding medical director. And we tried to model the really important thing about RightCare, and that's that this is about collaboration. It's about, you know, competitors coming together for the benefit of the community and identifying how we're still going to be competitors. I still want to eat, you know, Parag's lunch, but at the same time, I want to share the drink with him. But it's really about, you know, the community and really working together to find common ground. And that's what I find fabulous about RightCare. And so I want to thank, you know, Parag and all the other co-directors who have been with me. We had several, and the new co-directors who are doing such a great job. And thank you for this outstanding honor. You know, it's a baby whose birth now is starting to, you know, grow, and eventually we hope be a continued leading force of providing the collaboration that will allow improved care in the Sacramento region around cardiovascular disease and perhaps even further. But thank you for coming and for still continuing to support this, and appreciate it. And by the way, I also want to thank Dave Herbert, who's here, who's my boss, who has allowed me to continue to do this work, recognizing the importance for our organization, Southern Independent Physicians, and for you know, the community to continue to collaborate. And so thanks, Dave. I really appreciate your support. So thank you.
So Dr. Revelo is awfully used to me putting him on the spot. When we talked last Friday, we talked about the important contribution that Dr. Revelo has made in Sacramento, particularly to the topic, I mean, so many topics, but one of them near and dear to all of our hearts is better hypertension control. So one of the things that Dr. Revelo did is he led a pretty strong fight to get some systematic improvements in hypertension in the area. And did you want to just say a few words about what you're doing at Sutter?
Yeah, well, first we stole an idea from Geisinger and created the pocket cards that I think were actually very popular. And I think Susan had a lot to do with it, and I want to thank her as well. But that was one of the products of RightCare that I think continue to have some positive impact. And then one of the things that, and I think with Dave's help, of course, is identifying that we have a huge opportunity within our independent practices to work together to improve hypertension control, recognizing that for every patient, for every 40 or 50 patients we control, we're actually going to save a stroke. And so that's huge to know that. And so we've had a huge opportunity within my organization. And one of the things that we've done is now create a program to incentivize our specialists to get involved with hypertension control and to provide us with data on patients who are not in control, so that we can start working with those patients, identifying them when they come in and see the specialist. And it's really creating a quality initiative and a quality incentive for all our specialists. So that's been ongoing now for since we started this year, and we're already seeing some real benefits, and our numbers have increased dramatically in terms of the number of patients with a diagnosis of hypertension or in control. And it's good to know that with every 40 or 50 so patients, we're going to be preventing a stroke. That's really great news. And so I think it drives us even more to try to figure out, well, how do we do this even better? So, and much thanks to RightCare.
Well, thank you so much for your ongoing leadership in the community and for partnering with us all these years. And we're looking forward to having you with us over time. And we have a beautiful group here. We have all the main health systems with us today to hear from the National Women's Health Leader, Dr. Amparo Villablanca, who you helped introduce RightCare to. And I want to just say that although the grateful patient could not be here today, we know that we saved at least one life from this room by having a patient say to me, I have uncontrolled hypertension and I don't know what to do. And I sent that woman to see Dr. Villablanca, and Dr. Villablanca stabilized her, and she is thriving. So this is somebody who'd been in and out of the hospital, and so we're going to hear today about how differently women need to be treated for their various cardiovascular issues. And I apologize if I'm speaking more slowly than usual, but I've hurt my back, and I am on very strong muscle relaxers. So I'm going to hand this back to our fearless leaders and say thank you, God bless you, Dr. Becker.
Jose, you can run, but you can't hide, so we expect to see you back here as well.
Well, a lot slower now.
So it's my great privilege on our 6th birthday to continue the legacy that Dr. Arevalo laid down by introducing our next speaker. Our next speaker is currently a professor of cardiovascular medicine at the University of California, Davis, and holds the Franza Lazda Endowed Chair in Women's Cardiovascular Medicine. She's charged with developing and fostering excellence in education, research, and clinical care in cardiovascular diseases in women. And she founded the, in fact, program in 1994 and became director of the women's program at UC Davis, which was literally the first women's heart program in the nation at that time. So Dr. Villablanca has numerous awards here, which I cannot have time, because she won't have time for her talk, to elaborate on. But she has numerous honors and rewards, awards including Regional American Heart, Gold Award, Leadership, UC Davis, Lifetime Achievement, California Department of CDPH Award for Extraordinary or Excellence in Community-Based Medicine for Women's Health Leadership. And importantly, which I've left out, is she was actually one of my fellows. And as a cardiovascular fellow, you always look upon them and say, you know, it's a competitive program. I expect all of my fellows to be stars. And literally they all do become stars. But every once in a while, one of them becomes an exceptional star. An exceptional star that goes far beyond what you ever expected of that individual and continues to outperform in intensity, brightness, and duration. So I'd like to introduce not my star, but our supernova star, Dr. Villablanca.
Bill is just a unique person, and I really thank you so much for that incredibly generous introduction. I am really delighted to be here again. I was here 6 years ago, I guess at the birth. I didn't realize it was your birth, Patty. But I was here 6 years ago, and I really enjoyed speaking to this group. And I'm looking forward to doing so again. And to set the stage for my talk, I want to tell you how this presentation came about, because I'm not going to talk about any one topic in heart disease in women. Instead, I'm going to talk about a variety of topics and try to highlight the evidence-based guidelines in those areas and kind of the key things that the guidelines draw us to in terms of what are the key aspects of care that we need to be paying attention to. And as you know, our prior president and first lady were and are very physically unhealth conscious. And they continued Laura Bush's legacy of supporting women's heart care. She was a tremendous advocate for women's heart care and became a spokesperson. And at the end of President Obama's presidency, he requested that we, Women Heart Program directors, summarize what had been accomplished over the last 10 years in women's heart care. And as we were doing this, we thought, how can we frame this so that it's helpful to more than just the president, so that it's helpful to health professionals and those that are in health management and health policy. And so we came up with this concept of let's take all of our guidelines and pick out the evidence base that really points to gender differences and specific aspects of care that pertain to women. So we published this last year in Journal of Women's Health, if you want to look at the summary paper. And I'm going to go through the data, and then at the end, I'll just put up the list of all of the references of the guidelines if you want to look them up. But I think cardiology is so unique because, to my knowledge, it's the only discipline where we have gender-specific guidelines. I don't know of any other discipline where that exists other than, of course, UN, but that's sort of a gender-specific specialty. So we do have gender-specific guidelines, and the field is so rich. So I want to talk then about advances in cardiovascular health for women over the past decade in the context of guidelines, recommendations for practice. So this is what I thought we would talk about. So first, just so that we're all on the same page, the epidemiology of cardiovascular disease in women, which will include coronary heart disease, stroke, valve disease, heart failure, all of cardiovascular disease. And then there's 7 areas of progress, 7 key areas of progress over the last decade where we have evidence base, and they relate to primary prevention and community care, because we have to remember that primary prevention, trying to prevent a disease, has a large component of community health education and health awareness and health promotion. And then secondary prevention of those with established disease, stroke in women, which is a major killer, heart failure and cardiomyopathies, including those that are unique to pregnancy. Ischemia with non-obstructive coronary artery disease is a very important and critical area. spontaneous coronary artery dissection, which is often misdiagnosed as myocardial infarction in women that have no risk factors. I'll say a little bit about arrhythmias and device therapies, and then just summarize the guidelines, and then I have a short quiz for you. Are you ready for that? I'll just be a very brief quiz. I promise it won't be too hard. Okay, so just so we're all on the same page, let's start with National Center for Health Statistics data about the leading causes of death for all men and women in this country. And this is the latest data, which I think is 2014. And you can see that the leading cause of death, cardiovascular disease, is for men, is killing currently a little under 400,000 men, and for women, a little more. So cardiovascular disease is not only the leading killer in this country, but cardiovascular disease in women is the leading killer. And that, I think, is point number one. The leading killer in this country is heart disease in women. The other interesting point is that if we take all cancer deaths combined, not just breast cancer, but all cancer deaths combined, they do not equal the total number of cardiovascular disease deaths. And most of our patients and those that we serve, of course, think that, falsely, that breast cancer is their leading killer. And I'm not trying to pit one bad disease against another bad disease, but rather to put disease risk into context. Because if you don't think you're at risk for disease, it's very hard to practice prevention and to really have an open ear and mind as to what it is that you can do for a largely preventable disease. And then the other point that I think is very interesting here is Alzheimer's. So most of Alzheimer's is vascular dementia. There's, of course, a genetic component, vascular mixed dementia, and that's now the fourth leading cause of death in women, with deaths almost twice those from Alzheimer's dementia in men. And because it has a significant vascular component, I think it's important to point that out. Now, there is some good news, and that's that cardiovascular disease mortality trends have been improving steadily over the last decade, and now we're a decade plus, and you can see here the decline in total cardiovascular disease deaths, as well as in strokes, coronary heart disease, which encompasses at least half of total cardiovascular disease. So good news is that mortality is declining for men and women, but that wasn't the case until around 2000, where the declines were mostly for men, but not so much for women, despite the national campaigns. Now we're starting to, I think, with more recognition of gender-specific aspects of disease and guidelines and therapy that's responded to that recognition, see a decline in women. Though there's one group of women where deaths are not declining. Anybody want to guess what group of women that is? It's younger. Younger women with cardiovascular disease deaths are not declining. In fact, they're increasing. Those are women under the age of 45. And we still have a population at risk that thinks that they're immune. And we also have an increasing prevalence of cardiovascular risk factors. So we have a complete disconnect. And it's our jobs to educate those that we take care of and serve. Now, the death rates are not the same throughout the country. And this is a fascinating map from the CDC. It gets updated frequently. The deeper the red, the higher the death rate. So I showed you in the previous slide that overall it's about 280-some thousand. Yes?
I was wondering, do you have these figures even broken, down even more, like, stats on women of color, for
Yes.
example, and
Yeah.
then maybe even work trade, like farm worker women,
Yes, right, and National Center for Health Statistics has all of that data. I just wanted to just get us all on the same page. But you're absolutely right that there are health disparities, not just by age and by geography, which is the point I'm going to be making now, but also by race and ethnicity, and that African American women have the highest death rates, and interestingly, Latina women have lower death rates than Caucasian women do.
Could you
And
say that louder? You were away from the microphone.
that African American women have the highest death rates, and Latina women have lower death rates than non-Hispanic whites, basically Caucasians. So there are differences related to race and ethnicity. Thank you for helping me make that point. Differences related to age, although the data that I showed you was age adjusted. And then here now are differences related to geography, and they're really quite marked. Because what I showed you previously was the death rates around 280-some thousand. But look at these death rates here, almost 1,000 per 100,000 population, particularly in the southeast. But also, this is by counties in the US, but also look at the inland valleys of California. Pick your favorite state, the one you were born in, the one where you used to practice, the one where you trained in, the one that you came from. Pick your favorite state and just see how we're doing as a country, and you can see that really we have a tremendous problem in the southeast. Where right now life expectancy for the first time ever is declining in the southeast. So we have a huge problem there. I have family in Arkansas, wherever Arkansas is, over here somewhere. You know, when we first started to go to Arkansas after I married my husband, I couldn't find anything healthy to eat there, just about. It was really, really difficult. Now it's much better, but so much of it relates to our lifestyle choices. Yes?
I just wanted to request, I really want to hear what you're saying, and I know everybody does, and it's a little hard to hear you.
Okay, can we turn up our volume?
Can we turn up the,
That'd be great. Thank you.
Brian will take care of it.
Okay, thank you. I will try to speak up louder. Thank you. Okay, so the American Heart Association has said that we need to make more progress, not just because of the statistics, but because of additional data. So some of it relates to lack of knowledge and awareness. I've already alluded to that. So most women still are not aware that cardiovascular disease is their leading killer. We have made progress. You can see here that in 1997, when the Heart Association first started to publish their national survey data, only about a quarter of women knew that cardiovascular disease was their leading killer. Now it's a little more than half, and it's flat. This number has not really increased since 2012, and we need to break this impasse. And in addition, some health professionals also report lacking knowledge for the gender-specific aspects of cardiovascular disease. The second area where more progress is needed and has been identified by the Heart Association is in prevention, and particularly in the failure to link cardiovascular risk factors to disease risk and to action. And again, it's a sort of population at risk but feeling immune. And it's our jobs to educate those that we serve and take care of about this link. Not everyone knows that diabetes is a risk factor for heart disease, for example. Not everyone knows that obesity is a risk factor for heart disease. The third is the underutilization, specifically of evidence-based guidelines by health professionals. We still have a problem. So I mentioned we have a number of guidelines that cover gender-specific aspects of disease, but they're being underutilized, and we need to do better. And then under-treatment of women with proven therapies. And that continues to be a problem, and that relates to the underutilization of guidelines, but not exclusively. And then lack of comfort. 20% of health professionals report feeling comfortable, only 20%, treating cardiovascular disease in women. This is American Heart Association data. That's concerning because it's the leading killer. If only 20% of health professionals feel comfortable treating cardiovascular disease in women, we need to do more to educate health. So with that background, let's move to the 7 areas of progress, and I'll start with primary